In this presentation, I want to talk about some medical screening for physical therapy. So these are different issues, some of them musculoskeletal, but a lot of them non-musculoskeletal. So this is really consistent with your red flag screening in physical therapy. So we're going to try to run through as much as we can, and we'll see what we get to, but I'm hoping that we get to the majority of it. All right, so here we go. Okay. So medical screening for physical therapists. My goals for this presentation are to review some non-musculoskeletal diagnoses that we're going to want to screen for. Also want to, when they go away. Also want to review some relative screening questions and tests that we can utilize to get a better sense for, are these issues musculoskeletal? Are they not? Do we need to refer? Who might we refer to based on cluster of signs and symptoms that we're seeing and what we suspect may be their medical diagnosis? Not that we're making that diagnosis, but it's always nice to have an idea in our head of what is plausible so we can get that patient to the right individual for care. And I want to break this down as we're looking at screening questions and tests according to plausible diagnoses for different body areas, because to me that kind of makes sense. Instead of having everything possible, let's talk about the patient who comes in with neck pain and what are their main screening or red flags that we want to be aware of and rule out if we're treating them within our physical therapy plan of care or before we transition them under our care, so that we make sure that they're safe.
It's just like a nice review, and then just get to listen. We just started the second one.
Okay, somebody's on audio. That's okay. Yeah. All right. So, and then what I will leave you with at the end, we won't get to this and we won't go through this as a group, but there are 4 case studies at the end that you can use on your own to kind of test your screening knowledge. So those 4 cases at the end, and some of them are musculoskeletal, some of them are non-musculoskeletal diagnoses. I'll just tell you that. So you're really going to have to work to try to come up with the patients who are appropriate to treat and the patients who are appropriate to refer. Okay. Hopefully that let everybody in. Sometimes that doesn't work unless I stop sharing. So give me 1 second here. Okay, and we'll get back to it. All right, so what are your go-to red flag screening questions as a physical therapist? I'll let you think a little bit on this to yourself. I'm not going to give you a ton of time, but what are your go-tos as you're trying to screen out? Here's a list of some things that I tend to think about of issues that we want to rule out. So some of these are rheumatic diagnoses, some of them are vascular issues, organ referrals. We see fracture in there. That's a common one at different areas that we're going to want to rule out. We have different algorithms or criteria that we're going to have to kind of go through in different body areas as far as that goes. Yeah, so different things: infection, autoimmune, dysfunction. Here are some signs and symptoms that may indicate that physical therapy is not necessarily a treatment of choice, and we may need to refer to somebody else, another specialist. So if you're presented with a patient with saddle paresthesia, bowel and bladder dysfunction, what diagnoses might you expect? So in the lumbar spine, you want to screen for those particular signs and symptoms. Chest pain, shortness of breath, what further questions or tests might you want to use for that specific patient? And then what about your neuroscience? So face droops, arm weakness, slurred speech, FAST acronym, time to call 911. So that individual might be our stroke patient or devolving neuro symptoms. So for these tests, what I'm kind of referring to are, you're suspecting in lumbar spine, maybe cauda equina symptoms, chest pain, shortness of breath. You really want to rule out pulmonary embolism or myocardial infarction. So some sort of embolus or clot formation or heart attack, you want to rule out. How about these ones? So clusters, night pain, unexplained weight gain or weight loss, suspicious skin lesion. And then what if you have some systemic signs that you're presented with? Malaise, fever, chills, fatigue. That might not necessarily be the person who you're treating in physical therapy. Yeah, you want to treat their ankle sprain, but what if they have all these other factors? Or what if they don't have an ankle sprain and they're just coming to you with these constitutional factors that are causing maybe some joint aches and pains or muscle aches and pains. You really want to know that and kind of rule that out as an underlying cause or contributor to what they're telling you. So if you're presented with those specific things, in that first instance, we really want to rule out cancer. Do they have a history of cancer? Have they had these scans done? Have we cleared those issues? For specific suspicious skin lesion, we want to go through our ABCDEs and really think about things that may be abnormal or troubling that might need referral to a dermatologist or a physician. So our ABCDEs that may indicate some sort of pathological lesion or cancerous lesion, asymmetry, and borders. We're thinking about abnormal borders or irregular borders, color that's abnormal for C, so a red color, blue or black color, bleeding, things like that would indicate referral. D is going to be diameter, so I believe the cutoff is greater than 6 millimeters. Bigger lesions may be more indicative of faster growing cells or cancerous cells, and then evolving, so something that's changing very quickly versus a mole that's static that you have always had that's not changing very much. So maybe need for a biopsy, not that you're going to do that, but could be some further testing. And then your abnormal vitals and constitutional signs, you really want to check out what is their past medical history. Do they have conditions they're managing? Is it indicative of an underlying pathology that they may not know that they have? Could it indicate infection or some sort of immune system activation where you're fighting off something that's bigger and badder than a musculoskeletal mechanical type problem? Okay, so those are general things that we want to think about. This is kind of our physical therapy review of systems. So as we go through the different body systems, we really want to think about signs and symptoms that are maybe going to clue us in that this body system's affected versus our musculoskeletal system or our nervous system. Nervous system kind of crosses over. So if you have red flag neurosymptoms, a neurological issue that has not been diagnosed or that is an acute onset or evolving like a stroke, something like that, obviously we want to get that patient to the appropriate care, maybe a hospital setting. Some neuromuscular issues we're going to treat as physical therapists, and you guys know that, but just reinforcing that. However, these other body systems, we're really not experts in. We're not going to treat, we're not medical doctors, so I'm not going to treat GIGU issues. I'm not going to treat, for the most part, cardiopulm issues, although we can do a little bit of pulmonary physical therapy. We can increase cardiovascular endurance. Immune system, not going to directly treat. Endocrine, reproductive, integumentary. So just on the right, you have some hallmark signs and symptoms of those systems. That should be pretty straightforward for you. So moving into screening by body area. Again, don't forget your anatomy when you're going through these different body areas. So if you have somebody coming in with neck pain, think about what is regionally close. And the closer you are regionally, the more likely it is to need to be ruled out, or it could be a cause of pain. So in the neck, you're going to think about vasculature in the neck. If you're in the thorax and abdomen, those are places where you're going to be closer proximally to a lot of these organ systems. So GI, GU, reproductive organs as you move lower into the abdomen, low back, you're closer again to those reproductive organs. So that might be something that you need to rule out. If you're in the ankle, foot, big toe, you're probably not going to need to rule out organ system dysfunction. However, you may want to rule out things that are more systemic or rheumatologic or autoimmune. For example, first MTP or big toe is a common source of pain and dysfunction from gout, which is a rheumatologic disorder and not necessarily musculoskeletal or mechanical in nature. So just think a little bit regionally, and I think that's going to help you narrow down some of these screening questions and diagnoses. Okay, so for head and neck, what we want to rule out initially is we really want to rule out vascular causes or trauma-related causes. So fracture, you're thinking about using your Canadian C-spine rules, which are in the notes section there. So I'm not going to read through those with you, but you're going to want to ask questions based on what was the mechanism of injury. Was it a high-risk trauma? Do they have tenderness palpation? decreased range of motion, these sorts of things. And your cervical spine instability, your ligament testing objectively is very important on this, as well as some signs and symptoms of potential neurosymptoms for instability. If you have enough instability that you're getting spinal cord compromise, this person could demonstrate neural symptoms. Additionally, for vascular compromise or artery dysfunction, so you're not getting enough blood to the brain, you're not getting enough oxygen to the brain, you're going to have some sort of neurosymptoms. So with vertebrobasilar insufficiency, usually we think that vascular compromise is due to a certain head position, even though VBI testing, it doesn't have incredibly high validity or reliability. We do still seem to think that some sorts of positions can be provocative, although not necessarily in a pattern. So extension plus rotation seems to be more provocative than just purely extension or pure rotation. We do know, as you're going through VBI testing, and this is a common board question, is when you're in extension and rotation, you're actually placing increased stress on the opposite side vertebral artery as the direction that your head is turned towards or rotated towards. That just has to do with the research study findings where they're using Doppler ultrasound to detect blood flow. I don't have a good way to describe the mechanics of that versus just to say that it's all based on the Doppler studies for blood flow to the opposite vertebral artery, and they see compromised blood flow. So that's your VBI test. If you're going into extension and right rotation, you're testing the left vertebral artery. So just keep that in mind for your objective test. Aortic aneurysm, this could be the high intensity headache that does not go away. You can't affect it one way or the other. The other things we want to screen out with neck or cervical spine pain are cervical myelopathy or spinal cord compression. This is going to present with a positive upper motor neuron testing. So Babinski's, Hoffman's, inverted supinator sign. This is an individual who's going to have these pathological or abnormal reflexes and findings indicative of an upper motor neuron lesion. They also may have some symptoms of the 5Ds and 3Ns. So dysarthria, dysphagia, diplopia, drop attacks, dizziness, and then your 3Ns are numbness, nystagmus, and nausea. So if somebody presents with one or two of these, maybe you can justify it based on their past medical history or what they have going on. But if they have multiple symptoms with similar onset within these neurologic symptom categories, that's where you're going to want to refer this patient for further testing for safety. Okay, moving into the shoulder. Shoulder is one of those areas where we do have some referral, and we start getting referral from organ systems. So coming from the thorax and abdomen. Typically, left shoulder pain referral, we think of as a heart attack, MI, or heart and lung-based referral pattern. Right shoulder, though, can also be a source of referral from the gallbladder or lung. Left shoulder, we can see referral from spleen and diaphragm. Moving into thoracic and lumbar spine are red flag diagnoses that we want to rule out here. Cancer is a really big one in the thoracic spine, and metastatic cancer, so cancer that has spread to the spine as a secondary place of origin, so it's coming from some other body area, is not uncommon. And so screening for thoracic metastatic cancer is an important thing to keep in mind. So we do want to do that. I have a separate slide on risk factors for cancer, so I'm going to wait on that one. We do also want to screen for heart and lung referred pain within the thoracic spine because regionally we're close by. GIGU, you can have visceral referral pain, like we've talked about. And then as we get lower in the spine, especially towards lumbar and SI joint, we do want to screen out for ankylosing spondylitis. So this will often present as an individual who has stiffness, decreased motion, male, younger, but progressive loss of motion. And this is a rheumatologic condition. So it's an autoimmune condition. It will often present with an overlapping set of signs and symptoms that may seem mechanical in nature. And so we got to be careful that we really know the risk factors for that diagnosis. The other things that we want to make sure in the lumbar spine is that we're always screening for fracture and cauda equina, which are going to necessitate referral. So cauda equina, like we saw above, we're going to want to ask for changes in bowel or bladder function, primarily urinary retention and fecal incontinence. So urinary incontinence is not a red flag. In fact, pelvic floor physical therapists can treat urinary incontinence in some instances, but urinary retention or not being able to urinate is a red flag. So if somebody has not urinated in 24 hours, that is a red flag that necessitates being seen in urgent care. Saddle paresthesia is also a commonly described sign and symptom of cauda equina symptom or cauda equina syndrome. So numbness or tingling in the saddle area or genital area, saddle sign or saddle paresthesia is how it's described. So those two are things that we're always going to be wanting to ask patients with lumbar spine pain, as well as loss of bilateral lower extremity control, which can indicate neural compromise, ataxia, things like that, other neurosymptoms. Those two screening questions I think go a long way, are saddle sign and then loss of or change in bowel or bladder function. Heart attack signs and symptoms, these should be pretty familiar to you all, but I think they're worth listing. So shortness of breath, some atypical ones are maybe jaw pain, cardiovascular risk factors. You're going to be wanting to ask patients within their subjective, noting that females tend to present with signs of heart attack that may be more atypical. So jaw pain, neck pain, they may have an absence of chest pain actually. So that's one thing to be aware of. I think most of these you guys are aware of. And then PE signs and symptoms. So again, if somebody has a clot in their lung, they're gonna have pulmonary symptoms. So cough, shortness of breath. These individuals are often described as having pallor or turning PE gray. So really loss of color in the face, dizzy, sweating, things like that. And then this is our pain referral chart. So this is more for your reference. I'm not going to go through all these different areas, but suffice it to say that these different organs, based on their innervation and communication within the spinal cord with other areas of nerve sensory distribution, will have pretty, I wouldn't say well-defined, but regionally defined pain referral patterns that you can note if you're in these different body areas. So we've gone through some of them for the neck, shoulder, but as we move into the thorax and low back, those are nice ones to keep in mind. Specifically, so one thing that shows up a lot on our physical therapy board exams is these appendicitis special tests. So if you have positive findings on any of these tests, you can think appendicitis is maybe indicated, and that is a need for referral right away. So you want that patient to be taken care of right away by somebody other than you. So primary care doctor or urgent care clinic, walk-in clinic, something like that would be an appropriate referral. Right lower quadrant pain is going to be where this individual describes their pain. And then these are different positive tests. Again, I'm not going to read these to you, but this is for your reference. So these are all, if these tests are positive or you're seeing these signs, you may be performing these particular tests. Probably unlikely. Usually these tests are performed by a physician. However, knowing about them is important, and I think that's the key. But typically, what you're going to be looking for in your physical therapy exam is if somebody comes in with right lower quadrant pain that's not reproducible or not mechanical in nature. So your muscle testing, your palpation of muscles and joints in that area, your lumbar CPAs don't really change their pain. You might have pain with palpation as you can kind of palpate over the appendix and reproduce pain. So for example, if you palpate at McBurney's point, which is described as a point between on the right side of the body between the ASIS and the umbilicus. So right in that right lower quadrant abdomen area, if you palpate in that area, they could have tenderness. However, it's not going to be that you're palpating a muscle. You're going to be kind of right over that area of irritation. Okay, again, these are more for your reference. So visceral referral patterns, I tried to simplify a little bit. based on what structure is affected and where you're going to see pain and symptoms present. So right lower quadrant we said was appendix. Right upper quadrant is going to tend to be liver and gallbladder. And then on the left, we're thinking heart for upper quadrant and then stomach for lower. Those are stereotypical kind of quadrant referrals. Screening for red flags in the thoracic and lumbar. We want to screen out for fracture. So these are 5 risk factors that have been well described as putting a patient more at risk for spinal fracture. So increase in age, female over male, corticosteroid use. Again, we know that corticosteroids are catabolic, so they tear down tissues. And that's not only true for muscle, tendon, ligament, but it is true for bone. And so that degradation of bone tissue, if you have long-term or repeated corticosteroid use, can be risk for fracture. Trauma, obviously, and then pain or point tenderness. And then risk factors for cancer, as I alluded to earlier, there's certain factors that we want to be asking for in our subjective that are going to make it more likely that this individual who comes in with, for example, thoracic spine pain, it is due to maybe metastatic cancer or secondary spinal cancer. So increase in age, night pain, history of cancer is a huge one. So if they've had cancer in the past, it's more likely that it has metastasized to that area. And then, of course, non-mechanical, so you're not able to reproduce those symptoms. Night pain is a key one because oftentimes people with musculoskeletal origins of pain will describe night pain, but it's different than cancer night pain. So the individual with, for example, some sort of rotator cuff or impingement pathology at the shoulder will describe that, yeah, it's painful to sleep on that shoulder where they have dysfunction. It's painful to hold their body in a certain way, or maybe their arm across their body is painful. However, if they adjust, if they sleep on their back, if they sleep on their alternate shoulder, they're usually able to pretty readily get back to sleep. If they take NSAIDs, if they ice, those things will improve their sleep quality. However, for somebody who has night pain due to cancer, those change in positions aren't really going to alleviate their pain. And over-the-counter NSAIDs or ice isn't really going to help them. And then the other key thing you want to note is that somebody who is describing night pain due to cancer will oftentimes describe being woken up at the same time every night or very early in the morning. And this is likely due to the fact that we know that cancerous tissue is highly metabolically active. In other words, those cancerous cells are growing very quickly and they have high energy demands. Because of that, they produce a lot of heat. As you go to sleep, your basal metabolic rate slows down and your body heat drops. And so what ends up happening is that your body homeostatically can detect a marked difference between your basal body heat and metabolic rate and this area of cancerous growth. And so that discrepancy is oftentimes unsettling to the point that it will disturb people's sleep because they have this area of like heat and high metabolic activity that's kind of wonky or weird. And so that will contribute to the sleep dysfunction. And that's kind of one of the reasons that's been described for people waking up at the same time every night or having this night pain or night sleep dysfunction that isn't able to be treated. So I hope that made sense. And then cauda equina, talked about that. Okay, so hip and groin area, we're thinking what is regionally close? Well, gastrointestinal and genitourinary systems. So digestive system, but also our urinary system. So we're going to want to be screening for urinary issues. We're going to be asking questions about bowel and bladder, asking questions about digestion, asking questions about symptom response to things like eating, drinking, urination or defecation. And if we have any indication that those symptoms are linked to those sorts of things, it might necessitate a further look into these systems versus our neuromuscular system. In pediatrics, we do want to be aware of 2 diagnoses that necessitate referral, and those are SCFE and leg calf purse disease. So leg calf purse is going to be describing an avascular necrosis of the femoral head, and because of that vascular compromise or that vascular structure that's related, we don't want further injury or compromise, we do want to refer to a physician. And if that is the case, treatment is going to be indicated to try to preserve the vasculature. So this could be some sort of bracing. It could be some sort of internal surgery. With SCFE, so slipped capital femoral epiphysis, the head of that femur, the growth plate on the femur, has moved or has slipped, in which case, again, we want that bone to form in a healthy manner. And so treatment for that particular individual is going to be likely a surgery and a percutaneous, described as percutaneous pinning, where they pin that epiphysis in place so that it can grow and fuse correctly. And so those two diagnoses in pediatric patients are going to be key ones that you're going to want to screen for. Consistently, both of those younger individuals, pediatrics, are going to present with a limping gait, typically an increase in external rotation at the hip, a decrease in internal rotation, pain with walking, pain with weight bearing. Usually there's no mechanism of injury. It kind of just started. And so those things are always going to lead you to maybe suspect those diagnoses until proven otherwise and push for some further testing, most likely imaging, X-ray or MRI, to rule out those diagnoses if that's what you suspect. So a referral to a doctor who can make those imaging calls is really important in those cases. Okay, so moving down, we're at our elbow and knee, and elbow and knee, we want to rule out fracture as well. Fracture in the elbow typically is going to be due to trauma. Fracture, again, in the knee, typically mechanism of injury is going to be due to trauma. And at the elbow, what we're thinking of that's most predictive of fracture is just a loss of full motion. So inability to flex completely or inability to extend completely at the elbow is commonly described as a way to kind of rule in, rule out fracture, or at least necessitate further imaging. If somebody had trauma and they can't flex or extend all the way, they definitely need to get imaging. Also at the elbow, we want to be considerate of what's called heterotopic ossificans, or bone formation in an area that it's not supposed to form. So this could be in a bone, or sorry, bone forming a bone. This could be in a joint or in a muscle. So common spots for this to occur are in the elbow joint or in the brachialis muscle, elbow joint. This is also commonly described in the quadricep for lower extremity. So that's something that may indicate some adjustment in your physical therapy plan of care. You still might be treating that patient, but you definitely would want to adapt the aggressiveness with which you're prescribing or performing range of motion treatments on this individual. So if somebody does have HO, you're not going to want to perform aggressive passive range of motion because that can exacerbate the HO. You're going to want to back off. So that's something to think about. If somebody does have a loss of motion at a joint or extreme tenderness to palpation, or as you palpate within a muscle, you feel something hard, all of those things could indicate HO. Typically, it forms after trauma. It could form after neurologic injury. For example, a stroke. Sometimes stroke patients will have bone formation in a muscle because of the pathology involved. Okay, so at the knee, what are we thinking about? Baker's cyst could be a non-musculoskeletal diagnosis. So this is typically described as being in the posterior knee, and the popliteal fossa tends to be palpable, and or it will show up on imaging. So those are some ways that you can detect that. Fracture is going to be something that you look at with the algorithm of the Autoimmune rules, and that's going to be on a further slide, so we'll describe this here. And then lower leg, you're going to want to rule out DVT. Within the notes section, I have Wells clinical decision rules. That's going to be the way that you best rule out DVT, but your risk factors, going through your risk factors and trying to decide how many risk factors this individual has, how likely they are to have a DVT or a deep vein thrombosis, a clot, is going to be important for that individual. So somebody who has calf pain, redness, heat, swelling, you really want to rule out DVT, especially if they're post-surgical, post-immobilization, they have localized tenderness, and or an active cancer diagnosis. So those are some of the risk factors that are within that decision rule, and you guys can take a look at that, but that's kind of the patient that you're really going to want to screen for DVT. Autoimmune rules, here are the factors that are going to necessitate referral for suspected knee fracture. So this individual will need to get an x-ray. So if they have trauma and they have acute tenderness to palpation at the patella, at the head of the fibula, can't bend their knee more than 90 degrees, older than 55, can't bear weight. So can't bear weight is consistent with autoimmune rules, but also auto ankle rules. And wrist and hand, foot and ankle, we're getting away from the viscera, so we don't have as many red flags that have to do with referral. Hopefully you guys are noticing that. But some of our red flags or some of our referral-based diagnoses are going to be due to trauma usually, and or some sort of rheumatologic condition. So foot and ankle, auto ankle rules is going to be our differential diagnosis. And then we mentioned gout above, and then other rheumatic diagnoses or disease if an individual has multiple joints involved. So here are auto ankle rules. Suffice it to say, if you have tenderness at 4 spots, any of 4 spots, so medial lateral malleolus, navicular, or base of the 5th, metatarsal, those would be reasons to suspect fracture and want to get x-rays. Inability to bear weight, that's kind of your Cliff's Notes version of auto ankle rules. There's a citation in here for you. You can take a look at that. Wrist and hand, you're going to want to screen for fracture if there was trauma. And if you suspect a fracture, if you have tenderness to palpation at the distal radius, or most notably of the scaphoid because of its risk for a vascular necrosis or vascular compromise, you are going to want to refer for imaging. Sometimes that's going to be a fracture that's missed. And so even if a patient comes in with an x-ray and they have these things that are suggestive of fracture, it might be worth repeat imaging that individual because of that risk, especially at the scaphoid. If you have wrist pain that's not reproducible, maybe due to a ganglion cyst, so that can be detected. Sometimes you can feel those via palpation, but oftentimes that's going to be an imaging diagnosis. And then again, polyarticular, if you have multiple small joints affected, hand, wrist, fingers, toes, you're going to be thinking more rheumatic disease, multiple joints affected, versus a purely musculoskeletal cause. And rheumatoid arthritis is going to be one of the typical diagnoses here. So rheumatism is any of a various condition characterized by inflammation or pain in muscles, joints, or fibrous tissue. Wow, that sounds a lot like musculoskeletal disease. So again, we're going to want to be careful that we try to screen out for this disease. And if anything shows up in this patient's history that is atypical or not quite characteristic or doesn't quite fit, we're going to want to ask some more pointed questions to try to determine if the source of their pain and complaints is due to maybe a system-wide issue or a rheumatic issue. Autoimmune cause, basically, is what that describes. So there are some blood tests and family history genetic testing that can be suggestive of some of these rheumatic diseases. So the anti-nuclear antibodies, anti-citrulline antibodies, are things that will show up within an RA workup. Down at the bottom, these are the different rheumatic disease diagnoses. And then what I've done is I've created a little bit of a table here to try to dial in what are some signs and symptoms that are indicative of these specific diseases that may clue you in. Excuse me. So RA is going to be polyarticular. And like I said, so fingers, hands, wrists, small joints of the hands and fingers are going to be affected. Sometimes you'll see nodules and swelling, but usually those are later developments. And then they're likely to have some sort of positive antibody testing or markers of active inflammation. So elevated C-reactive protein or elevated ESR, erythrocyte sedimentation rate, are going to be indications of more global systemic inflammation. Psoriatic arthritis, you're going to see usually DIP is affected, and psoriasis is going to be your giveaway. So some sort of skin lesion, you're thinking more of a psoriatic arthritis versus RA. Gout, like we said, stereotypically is going to affect the great toe, the first MTP, and then you're going to have some sort of trigger for the gout. Usually it's a food trigger, seafood, red meat, alcohol. It's due to these uric acid deposits in the joint, and that's what's causing the dysfunction. Ankylosing spondylitis, like we said, usually presents with a younger male individual, usually have morning pain. It will describe stiffness in the morning and progressive stiffness that gets worse. If you do have imaging later in the disorder, you will see on imaging the fusion of successively, and it's described as kind of a marching upward disorder, SI joints, lumbar spine, thoracic spine, and postural dysfunction, but that'll be later in the disease. And exercise tends to help these individuals. So that could be a clue that it is AS. These are key defining features. A lot of what I talked about prior. The one that I wanted to note that may show up for you guys is this reactive arthritis, Reiter syndrome. And the easiest way to remember this one, this is kind of a stereotypical rheumatic disease, is can't pee, can't see, can't climb a tree. So this is an individual who has inflammation or irritation of the urethra, the uvea in the eye, and then some sort of joint dysfunction. And those 3 cardinal symptoms are indicative of Reiter's. Okay, so I think I made it. There are more notes in the notes section for you, and especially on this slide, we have kind of the 5 risk factors for ankylosing spondylitis, but that's what I wanted to get to within this presentation. If you have any questions, please let me know. The other thing I wanted to note is the cases follow, and those are the next 4 slides in this presentation are the cases. So go through those cases. If you want to on your own, test your screening based on what we talked about. And then the last slide will be the answers. So don't get to the answers too quickly. Really test yourself on these cases, and good luck with your physical therapy medical screening. All right. Thank you guys.